A
very good morning to one and all. So in today's Journal Club, first we'll discuss the article on treatment for dyskinesias and Parkinson's disease, a network meta-analysis of randomized control trials. So as we all know, Parkinson's disease is the second most common neurodegenerative disease, and dopamine replacement is the cornerstone in treatment. As the disease progresses with chronic levodopa administration, the patient develops motor fluctuations and dyskinesias. This is seen in around 20% of patients with Parkinson's disease within 5 years of disease onset. And this prevalence increases to 70 to 90% after sustained exposure to levodopa for more than 10 years. Most frequently, it presents as stereotypies, chorea, balism, dystonia, and myoclonus. It usually starts in the foot ipsilateral to the side that is most affected by the Parkinson's. Even though the patients report to have lower quality of life scores, they usually prefer being on with dyskinesia than being off without dyskinesias. There are mainly 3 types of dyskinesias that is observed in Parkinson's disease. The first and most commonly observed is the peak dose dyskinesias. They usually present with stereotypic coriform and ballistic movements of the head, trunk, limbs, or even the respiratory muscles. So in this, usually the patient has Parkinsonisms. After the intake of levodopa, there is an improvement. And at the peak dose of levodopa, the patient develops dyskinesias, following which there is an improvement, after which the effect of levodopa wears off and the patient again develops Parkinsonism. The next type of dyskinesia is the diphasic dyskinesias. In this, the patient has a Parkinsonism, following which he takes levodopa. After intake of levodopa, the patient gets dyskinesia, after which the patient has a period of improvement, after which, again, once the dose of levodopa starts to wear off, there is again a dyskinesia. And once the dose completely wears off, the patient again develops Parkinsonism. And the third type of dyskinesia is the off dyskinesia, dyskinesia that usually presents as dystonia. In this, once the effect of levodopa totally wears off, the patient develops dystonia. This is usually presents as early morning or nocturnal painful foot cramps. So the peak dose dyskinesia usually presents in the upper limb, trunk, and usually involves the face also. The diphasic dyskinesia is usually present with lower limb dyskinesias. And the off dystonia also usually presents with distal foot dystonia. So the pathophysiology of dyskinesias and Parkinson's disease is very complex and not yet fully elucidated. So normally the dopamine stimulates the direct pathway through the D1 receptors and inhibits the indirect pathway through the D2 receptors. So in Parkinson's disease, there is an imbalance between the direct and indirect pathways with an overactivity of the globus pallidus internus that inhibits the motor thalamus, in turn causing Parkinsonism. So in the early stages, the dopamine transporters take up the exogenous dopamine from the levodopa and store it in presynaptic vesicles. But as the disease advances, there is severe loss of dopaminergic terminals in the dorsal putamen and the loss of dopamine transporters. So in turn, there is an incapacity to store dopamine. Therefore, when the patient takes levodopa dose, there is a sudden release of dopamine and this resulting in dyskinesias. This is one theory that is put forward for the pathophysiology of dyskinesias. There are also other theories that is put forward, including the pulsatile stimulation of the dopamine receptors and also the action of the other neurotransmitters other than dopamine, including serotonin, glutamate, and acetylcholine. And in the more advanced stages of the disease, there is also a wearing off phenomenon for both Parkinsonism exacerbating a dyskinetic effect. This occurs with levodopa at low plasma concentration. So either low or high dose of levodopa can cause dyskinesia in the late stages. So coming to treatment of dyskinesias, the usual approaches which we take in our day-to-day routine practice for peak dose dyskinesias, administering smaller and more frequent doses of levodopa is advised and more immediate acting formulations of levodopa is advised. For diphasic dyskinesias, reducing the dose of levodopa and increasing dopamine agonists, and use of a levodopa carbidopa intestinal gel, which provides a more stable concentration of levodopa. For off dystonia, adding long-acting formulations or taking the medications right before the bed and then again after waking up is advised, along with COMT or MAO-B inhibitors at bedtime. Other drugs, apart from levodopa, adjusting the dose of levodopa, COMT and MAO-B inhibitors have found to slow down the breakdown of levodopa and dopamine, thus resulting in reduction in dyskinesias. Other drugs which has been used and found to be effective is NMDA receptor antagonist amantadine, and also safinamide is a useful option that has dual mechanism of action, that is MAO-B inhibition as well as glutamate antagonism. So the pre-existing update on the treatment of dyskinesias and Parkinson's disease was published in 2018 by the International Parkinson and Movement Disorder Society. In this, for the treatment of dyskinesias, the clinically useful strategies were found as amantadine, clozapine, levodopa, carbidopa, intestinal gel, bilateral DBS surgery, or unilateral palidotomy. So with this, we can come to today's article, that is on the treatment of dyskinesia and Parkinson's disease, a network meta-analysis of randomized control trials. This was published by Yan et al. In the Movement Disorders Journal in March 2025. This study was funded by the National Natural Science Foundation of China. So in this study aimed to evaluate the comparative efficacy and safety of treatments for dyskinesia and Parkinson's disease. So for this meta-analysis, they've enrolled study in which the PD patients were recruited who met the MDS UK PDS brain bank criteria and were experiencing dyskinesias. The studies had to compare interventions with control or with each other, and reporting was done at least with one of the following outcomes, that is scores on dyskinesia rating scales, on time with dyskinesia, and on time with troublesome dyskinesias. And the study design had to be an RCT. And the studies with the study protocols alone, post-hoc analysis, letters, conference abstracts, editorials, or reviews were excluded from the study. And studies with a sample size of less than 10 were also excluded. And studies with missing data or the data which could not be extracted were excluded from the study. So the primary efficacy outcome was a change in scores on dyskinesia rating scales from baseline. And for secondary efficacy outcome, the study has looked at changes in on-time with dyskinesia, on-time with troublesome dyskinesias, quality of life, levodopa equivalent daily dosage, UPDRS-3 score, and off-time from baseline. And for the safety outcomes, they've looked at the incidence of adverse events, serious adverse events, discontinuation rate, and worsening of Parkinsonism. And since the progression of disease may interfere with dyskinesia improvement, this data was extracted at time points within 1 year of initiation of the intervention. And 3 reviewers have assessed the quality independently, and any divergence was discussed with the 4th reviewer to reach a consensus. So the data analysis for binomial likelihood was used for dichotomous data and normal likelihood for continuous data. For continuous variables, the data was calculated as mean difference or standardized mean differences between the control and intervention arm. And this standardized mean differences at a value of 0.2, 0.5, and 0.8 were interpreted as small, moderate, and large. And another parameter which they've looked at is the surface under the cumulative ranking curve, which was calculated for to rank interventions for each outcome. The higher the value of the surface under cumulative ranking curve or SUCRA, the more efficacious the intervention was. And for each intervention, each study, they've given a certainty of evidence. So the certainty of evidence divided as very low, low, moderate, and high certainty of evidence. This is basically, they ranked on the basis of the risk of bias, indirectness, inconsistency, imprecision, and publication bias, which reduces the certainty of evidence. And if the study has a large effect size, establishing dose-response relationship, and if residual bias or confounding is expected to strengthen the intervention, then this increases the certainty of evidence. So with this, all the studies were looked at from the database, and several studies were excluded depending on the exclusion criteria of the study. And a total of 85 studies were taken for analysis. And these were the interventions that were studied in these patients. 9 studies on amantadine immediate release was done, 7 was taken, 7 studies on ST and DBS, 7 on istradifilin. And we can see some newer particles here that were studies, that is AFQ056, ADS5102, and OS320. So this OS320 is an immediate release and extended release amantadine combination that was studied. And this was published in 2022 with the LA Lit studies. And it was shown that this immediate and extended release amantadine was found to improve dyskinesias in the patients. Another newer molecule that was looked at is this ADS5102. This is also an extended release amantadine, which was also found to be efficacious in the previous studies. And the side effects reported were false visual hallucinations, peripheral edema, and constipation in these studies. Another newer particle which was studied is mavoglurant. This is a glutamate antagonist, which was also studied in multiple RCTs. This is a meta-analysis of 6 of those RCTs in which it was shown that this pooled modified abnormal involuntary movement scale favored mavoglurant group above placebo. So coming to our meta-analysis, in this 85 RCTs involving 39 treatments were studied, enrolling 13,826 PD patients. The mean age of participants were 47 to 69.5 years, and male participants were seen at a percentage of 29 to 82%. All trials provided data on scores of dyskinesia rating scales within a 1-year follow-up, and only 3 trials reported outcome at time points longer than 1 year. So coming to the efficacy outcomes, this is the order in which there was improvement in dyskinesia severity rating scores with the certainty of evidence provided. So the highest improvement in dyskinesia severity rating scores were seen with GPA-DBS, followed by levodopa-carbidopa intestinal gel, followed by STN-DBS, followed by oral medication that is amantadine immediate release, followed by palidotomy, followed by this amantadine extended release formulation, followed by clozapine and this amantadine immediate and extended release combination, followed by mavoglurant, that is a glutamate antagonist. So similarly, the surface under cumulative ranking curve. So this gives the percentage of efficacy of the drug, in which again it was in the same order: GPA, DBS followed by LCAG. Among oral preparations, amantadine immediate release had the highest surface under cumulative ranking curve. So most of the studies were comparing between placebo and the treatment. So there were some studies that compared between treatment groups. So one of those was GPA-DBS versus STN-DBS, in which GPA-DBS was found to be superior. Similarly, this newer molecule OS320, that is immediate and extended release combination of amantadine, it was found to be less efficacious than GPA-DBS and STN-DBS. And also this AFQ056, that is the mavoglurant glutamate antagonist, it was also found to be less efficacious compared to the surgical options and the immediate release amantadine. So this is a network graph that is showing the studies. So here in this circle, we can see that the studies, most of the studies were compared between the control and the treatment arm. So the thickness of the line represents the number of studies that has been done, and the length of the line is denoting the duration of the trial. So here we can see that amantadine had the highest number of RCTs with the longest follow-up. Most of the studies were comparing between control and the treatment arm. There were few studies that were comparing between the treatments, that is mainly the STN-DBS versus GPA-DBS. And there are studies which has also looked at on-time dyskinesias between the control and the treatment arm. Similarly, on time with troublesome dyskinesias, and the levodopa equivalent daily dosage also was studied with the control and between the treatment arms. So looking at the results of the studies, these are Vitruvian plots. So here we can see that the outer layer, that is this purple marking, that denotes the surface under cumulative ranking scale. So more darker this purple color is, the more more surface under cumulative ranking area curve that the intervention had. So here we can see that the GPA-DBS, the dyskinesia scale score, the Sukra score was very high, and that this is more densely graded. And coming to the dyskinesia scale score, there was significant improvement, and with the GPA-DBS, there was significant reduction in the dyskinesia scale scores that we can see here. Incidence of adverse effects and incidence of serious adverse effects were very low, and which is not statistically significant in case of GPA-DBS. Similarly, with levodopa-carbidopa intestinal gel, the dyskinesia scale scores, there was significant difference, significant surface under cumulative ranking curve, and there was significant difference in the dyskinesia scale scores between LCAG compared to placebo. There were incidents of adverse effects, but it was not statistically significant. Similarly, for STN-DBS also, there was a significant improvement in the dyskinesia scale scores. The other intervention, looking at the amantadine immediate release, there was a significant improvement in dyskinesia scale score on time with dyskinesia and on time with troublesome dyskinesias. And however, there was not significant incidence of serious adverse effects that was noted here. Coming to the newer molecules, here we can see that with this ADS 5102, that is extended release amantadine, there was significant improvement in the dyskinesia scale scores. However, there was significant incidence of adverse effects also, including the serious adverse effects also. And compared to that, the OS 320, that is the combination of immediate and extended release amantadine, also had significant improvement in the dyskinesia scale scores and on-time and troublesome dyskinesias. However, the incidence of adverse effects were also significantly worse in these patients. And this mevogluran, that is the glutamate antagonist, also had significant improvement in dyskinesia scale scores and on-time and troublesome dyskinesias. However, there was also significantly worse incidence of adverse effects in these patients. Coming to the forest plot, that was grading the dyskinesia scale scores, as we had seen before in the order of efficacy, it was GPA DBS followed by levodopa carbidopa intestinal gel, followed by STN DBS, followed by amantadine and the newer interventions. And in treatment of in incidence of on time with dyskinesias, amantadine in immediate release followed by clozapine has the highest reduction in on time with dyskinesias. Similarly, on time with troublesome dyskinesias also, amantadine immediate release had the highest effect, followed by the amantadine extended release and the mevogluran. Quality of life, regarding quality of life, GPA DBS had the highest improvement in quality of life, followed by LCAG and STN DBS. And off time reduction was the best seen with LCAG, followed by this newer molecule extended release amantadine. And improvement in UPDRS 3 scores were seen better with STN DBS followed by GPA DBS. Comparing the safety outcomes, it was seen that the newer molecules were found to have poorer, found to have more adverse effects, and including the serious adverse effects also. That is amantadine extended release and the mevogluran was found to have more higher incidence of adverse effects and discontinuation rates. So coming to the discussion, from this network meta-analysis, GPA DBS was found to be the most effective therapy for treating dyskinesias. And among oral medications, amantadine immediate release was found to be most effective. There was moderate certainty of evidence for GPA DBS, amantadine, the extended release amantadine, palidotomy compared to control. And very low certainty of evidence was seen for levodopa carbidopa intestinal gel, STN DBS, clozapine, and the newer molecules of immediate and extended amantadine combination and the mevogluran. In GPA DBS outperformed STN DBS for patients with dyskinesias who were simultaneously experiencing serious wearing off, and novel medications were not superior to amantadine immediate release and raised safety concerns also. So coming to GPA DBS, this was the this intervention had the highest probability of being the most effective anti-dyskinetic therapy, and there was greatest improvement in quality of life and acceptable safety profile. And it was notable that this GPA DBS had improvement in dyskinesia without simultaneously reducing the levodopa equivalent daily dosage, indicating that GPA DBS could directly suppress the dyskinesias, and it had higher probability of performing better than palidotomy in reducing dyskinesias with better safety profile. So comparison between GPA and STN DBS, STN DBS reduced dyskinesias and levodopa equivalent daily dosage, but in patients with subthalamotomy, there was no significant reduction in dyskinesias and levodopa equivalent daily dosage. Hence, the impact of STN DBS might not be direct, but rather achieved indirectly through the reduction of levodopa equivalent daily dosage. However, GPA DBS caused significantly larger suppression of dyskinesia compared to STN DBS. So from this, it was seen that GPA DBS had a direct action on dyskinesia. However, STN DBS acted on dyskinesia through reduction of the levodopa equivalent daily dosage. So when reducing levodopa equivalent daily dosage is not an option due to risk of worsening of motor performance, GPA DBS may be a preferable choice for patients with dyskinesia who are also experiencing serious wearing off effects. Other treatment option which you have seen is levodopa carbidopa intestinal gel. It had significant benefit with a large effect size in the studies. And advantage of LCAG is that it can achieve continuous dopaminergic stimulation to address the narrow therapeutic window between the off state and the peak dose dyskinesias. So the levodopa equivalent daily dosage did not significantly decrease with LCAG. So the stable L-DOPA concentration that is provided by the LCAG is what helps to suppress the dyskinesias. However, there is only one open labeled and later blinded RCTs, and hence the certainty of evidence was very low for LCAG. Coming to amantadine, this had the highest probability of being the best anti-dyskinetic treatment among oral medications with an acceptable safety profile. So three preparations of amantadine were found to be effective, that is immediate release, extended release, and a combination of immediate and extended release. And all these interventions were found to be more effective than control in improving scores on dyskinesia rating scales. However, amantadine extended release was found to have more safety concerns. This can be attributed to the higher amantadine plasma concentrations that was achieved with these drugs. And it is also to be noted that head-to-head comparison between immediate and extended release preparations are not currently available. Another drug which was found to be effective is the anti-glutamatergic drugs, that is AFQ056, that is the mevaglurant. It was found to be more effective than control. However, there was very low certainty of evidence with small size and increased safety concerns. Other interventions, including NMDA antagonists, AMPA antagonists, and glutamate receptor modulators, were not found to have any significant effects. Other interventions, including serotonin agonists, nicotinic acetylcholine receptor agonists, adrenergic agonists, and adenosine antagonists, were also not found to have a significant effect on the improvement in dyskinesia. Another drug which was found to be effective was clozapine. The mechanism is by blocking D2 receptor and the 5-HT2A receptors. However, quetiapine was also studied and was not found to be effective in treatment of dyskinesias. The study had certain limitations in that there was a scarcity of head-to-head intervention studies. Most of the interventions were comparing between the control and the intervention. And the evidence for diphasic dyskinesia or off-period dystonia was insufficient. Most of the studies looked at peak dose dyskinesias alone. And long-term follow-up was not available for most of the studies. Only 3 studies had a 1-year follow-up. And 3 RCTs were even acute trials lasting for less than 1 week. And most of the studies were primarily designed to address the motor fluctuations or the quality of life. And dyskinesia rating was considered only a secondary endpoint in most of the studies. So as a critical appraisal, this study had a large scope and a very rigorous methodology with a comprehensive outcome. But some treatments are very low certainty of evidence, as we had seen, with poor generalizability. And there was limited direct comparisons. And some of the safety outcomes were underreported in the study. So the treatment decision for dyskinesias and Parkinson's disease should be tailored based on the personalized assessment of patient factors and individual needs. And there is more need for more studies that prioritize dyskinesia rating scales as primary outcome measure, employing standardized scales across the different studies. Dopamine. Dopamine receptor block.
Other complications are a major like roadblock in the treatment of Parkinson's disease as the disease advances. So the classical teaching is that it is levodopa induced. So if you don't give levodopa, you won't have motor complications and you won't have dyskinesia, which is a very troublesome motor complication. It's a common clinical observation that patients with Parkinson's disease is often an asymmetrical disease. You have the onset is generally on one side, and then it remains asymmetrical almost throughout the course of the disease. So when you give levodopa to patients with Parkinson's disease or any form of treatment, the dyskinesia generally starts on one side. It starts on the side where the disease started. So why it should occur only on one side if it is purely levodopa induced? The levodopa which you give goes to both sides of the brain. So that is a question which often clinicians face with. And then a lot of recent evidence has now come over the past 10 years or so that it is not levodopa which is the culprit for levodopa-induced dyskinesia. It is the neurodegeneration, the peculiar neurodegeneration which happens in PD. That is very unique because there is an extensive presynaptic dopaminergic denervation. Your Substantia nigra goes and all the presynaptic dopaminergic neurons go, but postsynaptic remains intact almost throughout or till very late stages of the disease. This doesn't happen in other Parkinsonian syndromes, like for example, PSP or MSA. You have some presynaptic, but equally or even stronger postsynaptic neural depression. So this presynaptic depression is related to postsynaptic mechanisms. Intact postsynaptic mechanisms is an essential prerequisite of neurodevelopment spaces. And obviously, the neurodegeneration which happens in the presynaptic, which determines the severity or which determines the induction of neurodevelopment or so-called neurodevelopment. So when so this kinesis is a phenomenon which happens when you have dominant replacement in a striatum where there is extensive presynaptic penetration with interaction postsynaptic mechanisms. So if the therapy is potent, definitely you will have dyskinesis, which indirectly means that dyskinesia as an indicator of treatment success. So if your treatment is really effective, successful, and if there's an excellent motor control, then you are likely to get some dyskinesis. It's really nowadays that dominant agonist will not cause that dyskinesia because it is not as effective. That is a simple reason. So levodopa is not a dominant. It's not toxic. It is not toxic changes in the spine. It is a potent therapy. So when it acts on an advanced disease with an advanced, it results in dyskinesis. So all the therapies other than the subject infections which control dyskinesia lead to an equally significant reduction in motor control. So whatever benefit you get with proper and dyskinesia, so in a patient with really high levels, only a moderate or mild or moderate substantive numbers can start the problem. There is no need to compromise or no need to withhold levodopa for fear of patients. Compromising the patient's quality of life. That is primarily evidence. And there are a lot of studies there. There are some studies in which compared patients was delayed significantly because access to medical there was patients from Sub-Saharan Africa compared to patients from Italian patients receive levodopa lead. Levodopa by therapy, treatment by therapy. While Sub-Saharan African patients, many of them are not identified. They were identified in the course of disease. Treatment was it was found that the time point at the onset of dyskinesia, if you take from the onset of the disease was that is Sub-Saharan patients receive at age or they have dyskinesia is not a duration of levodopa, but it is a duration of disease which is so there is actually no need to before levodopa. In younger patients, neurologic mechanisms can be developed. So in younger patients in whom the plasticity is small and then both are actually more expectancy and the symptoms are mild because the only but most and this study this is actually not a whatever information is was contained in this RNAs are probably and actually quantity more. It's well known that the TPA is most used for
రావట్లేదు వస్తుంది కానీ పైకి రావట్లేదు.
STNDBS is not to control this condition because it has got a very proper of symptoms and reduce the power of water. So, and that is one kind of suppression of this. But there are probably some direct mechanisms also because the practical experience that many of our patients who say STNDBS will have this. After surgery, they continue to say almost the same dose of dominant medications because they have this STNDBS of factor. but they do not experience mental experience. So there is some direct activity for so, but this is not a mass most. So PDPS is the most. That's all. More information from this analysis is that immediately start managing the release of the very water, the release of these operations, which is again practical observation for most of the operations. And many patients are experience side effects, so adverse effects also high. Now we have direct database, direct data surplus to support this practical observation. And then we were like more of Safety probably was more from the used for European businesses, but it was more complicated in this particular probably because there were more studies and some of the studies as well. So as Anagha statement, it is that we have individualized treatment for European businesses. We have looked at how severe it is. It's often an observation that European businesses are more of a concern for the physician and for the ladies in the patients. For many of the patients, it is not dyskinesia, but the off symptoms which are more troublesome. These are not if you are happy to see a patient who is sitting quiet rather than a patient who is dancing, but for the patient, it is just the reverse. He can accept it dancing, but he wants to. So many a time, we are receiving the reduced doctor-only medications in saints and dyskinesia patients. So studies have shown that quality of life is not very much affected by mind or moderate experiences. Only severe experiences are what is impairment for. So you should teach the patient to ignore dyskinesia. So you're not having severe dyskinesia, we have to look at sort of conditions.
So we'll move on to the second journal for the day. Myself, Dr. Rohith, under the guidance of Dr. Ashish, we are presenting this topic. This topic on LRK2 associated Parkinson's disease. Is it synucleinopathy after all was the question which was discussed in this article, which was published in 2025. So as an introduction to the topic, we have around 24 monogenic reasons why a person can get a Parkinson's disease, and it plays an important role in pathogenesis, clinical features, onset of symptoms in PD. And in Parkinson's disease, the pathological hallmark is alpha-synuclein positive intracellular inclusion bodies, which are called Levy bodies. And they are found selectively in vulnerable regions, as we all know, in the substantia nigra mainly. And we have many genes, which are, that is 24 genes. Now it is not named according to this PARC1 to 24, which was used earlier. Now it is mainly directly the gene names which we are using. So we have various pathogenesis and pathophysiology why these genes can can cause the Parkinson's disease, especially the most common, that is the Parkin gene encodes for the protein called PRKN gene, which encodes for the protein called Parkin, which is a component of a ubiquitin ligase complex, which is important for the autophagic lysosomal pathway, as we can see here. And which helps in clearance of the protein. And if that is impaired, then there will be a protein aggregation. And similarly, other proteins like SNCA and LRRK2. SNCA is a protein, is a gene which encodes for alpha-synuclein, and a neuronal protein which is involved in the vesicular trafficking the fusion of the neurotransmitters. And a defect in that gene will lead to the aggregation of the protein and misfolding of the protein, leading to the accumulation. Similarly, LRRK2 as well, which encodes for a protein kinase. The name itself is a leucine-rich protein kinase mechanism, which is important for multiple processes in forming this protein and eliminating this protein. And it helps in ubiquitation and the proteasomal degradation of this protein. And defect in that will lead to the accumulation of the protein, and that will lead to aggregation, and thus leads to an abnormal, meaning abnormal cell physiology, leading to the clinical features. So the most common among the genes are worldwide studies show GBA, that is a glucocerebrosidase enzyme, glucocerebrosidase producing gene, that is GBA1 gene, which is inherited as autosomal dominant, has got a highest risk factors of prevalence of 5 to 15% of all the Parkinson's disease of early and late onset. And 1 to 5% of all PDs have got, when the patients present in a late onset, like a typical PD, LRRK2 is the most common. And in the early onset PD, it is Parkin1, and the which is inherited as autosomal recessive pattern, is more common in the genes. So as we can see in the last column, GBA has got, usually we see Lewy bodies as a in the pathology, in the tissues of those patients. Whereas LRRK2 can have, mostly it has Lewy bodies, but there are patients, or there are samples where there are no Lewy bodies which are seen in the tissues of those patients. And similarly in Parkin, it is not there. So this heterogeneous presentation or heterogeneous appearance of these Lewy bodies in various genes led to this question whether all of those are truly a synucleinopathy, or there is a difference in the pathophysiology. So the same thing here as well. Parkin has got no there is no uncertain association of the Parkinson's type of synucleinopathy, whereas our core topic, that is LRRK2, in most cases there is this synuclein presentation, and there is a strong predisposition to the PD. However, there are few cases which does not have the synuclein as a deposit in their thing. So why they choose in this study LRRK2? Probably because it is the most frequent gene in the PD in the late onset population. However, this frequency is mainly from the studies which are coming from the Western population, although it is negligible in the Asian population. And this is located in chromosomal 12. And there are variants. There are definite pathogenic variants of, that is various genotypes, which have been classified as definitely pathogenic. Among them, in the short term, there is a G2019S genotype. And similarly, other R141C phenotype, which has been more associated with the synucleinopathy. And the LRRK2 closely resembles the typical PD, and it differs from the typical PD that not all of them have got a Lewy body deposition. And as I told, the few genotypes have got more predisposition, and younger patients and male sex has got more predisposition to this Lewy body formation. So in this paper, they discussed two main studies, which I'm going to discuss. One is the Jensen et al. Study, which was published in 2025, where they question telling whether the same question as some mutations in LRRK2 clinically diagnosed to be not have any Lewy body on autopsy. Is the pathology same or different? Was their question. So they used a method of identifying the synuclein monomers by a new assay, which is called a proximal ligation binding assay, where antibodies are used to bind to these synuclein molecules. And there is a dual antibody which they have used in this study. And with the help of these antibodies, they have used a proximal ligation mechanism, and then analyze and then forming this polymerase enzyme, and then identifying this molecule. So based on this dual antibody recognition and rolling over technology, this is called the rolling over technology, where they use a amplification method which produces a fluorescent signal at the site of the target molecule with the help of the interaction of these antibodies. And even the antibodies which they are using also will help in identifying the synuclein. Especially here, they have used a specific MGFR 14642 antibody, which equally detects the synuclein aggregates in whatever form it is, not only the Levy bodies. It identifies the oligomers as well. So they selected 6 Levy body negative cases, that is the LRK2 patients, and 5 Levy body positive patients, and 6 controls. So especially in the Levy body positive, they wanted to have those patients with Levy bodies. So they took this BRAC staging of stage 6 Levy body dementia patients. And in the LRK2, they took 6 patients, and most of them, the age was ranging from 61 till 94. And the disease duration was from 5 to 11 years. And the staging, the BRAC staging or the clinical staging was different in different patients. And they took a formalin fixed paraffin embedded tissue sections of 5 micrometer thickness from various sections of the brain, including medulla, pons, midbrain, posterior hippocampus, and amygdala, as I'll show in the next picture. And the staining methods, this is the original image. They differentiated the neuromelanin from the other substrates, and they defined the staining as particulate matter, Levy body like matter. So the two important definitions were in this, as we can see in this image which they have subtracted, the whiter part is the particulate matter, and the second image, the whiter part is the Levy body matter. So that is the two groups which they saw. And as I told, they took it from different sections. And this two groups, that is a particulate matter and the Levy body, as we can see in the first group of the images, they graded 1, 2, 3, and 4. And the second group, and that is the reddish brown pigments which we are seeing in and around the cell bodies, are the particulate matter. Whereas inside the cell body, which we are seeing is the Levy body like matter, which is again a darker brown or a reddish brown inclusion bodies which we are seeing in the cell bodies. So the results were, in the first row, it was the LRRK2, second row is the Levy body, and the third row was the control. So the results were in the LRRK2, in different sections of the brain, there were deposits of this brownish as marked in reddish brown particulate matter as marked in the arrows in different sections, predominantly in the posterior hippocampus and the amygdala, in the absence of Levy bodies. Whereas in the Levy body disease, we did not see, they did not observe any particulate matter. Rather, they observed more of the Levy body inclusion bodies. And comparing it to the controls, there were no such particulate or the Levy body deposits in the group. And the same thing here, what they depicted was in the, this is the particulate group, this is the Levy body group. Same thing which was showed us in the LRRK bar, we are seeing more of the particulate matter when compared to the other two groups. And in the Levy body group, Levy body deposits were more in the DLBD group rather than that of the LRRK2 group. So what was the observation was the substantial levels of alpha-synuclein aggregates, but there were no Levy body-like inclusions in the LRRK2 with no Levy body. So whereas in the particulate affects both the classical PD-related brain regions and also the other regions like inferior olivary nucleus and the pontocerebellar pathways, which are not implicated as a pathogenous as a site of implication in PD. So moving on to the next study, which they saw was a Sekia et al. Study, which was again published in 2025, almost at the same time, and the hypothesis almost remained the same. But they directly, the hypothesis was whether it is noted in the absence of Levy body. So they here difference between that study was they looked into the 3 different genotypes as well. That is the G2019S and P2020T and PR, the short term of chromosome, that is R1441C, 3 genotypes which they saw, and they also took the postmortem brain samples from Japan and USA and Japan and USA mainly, and they took 5 patients of each genotype and 5 controls. So the following regions, including the dorsal motor nucleus of vagus, medullary raphe nucleus, locus ceruleus, substantia nigra, midbrain, entorhinal cortex, hippocampus, putamen, caudate nucleus, and the neocortex were studied. And 2 contiguous sections with 2 different staining, including the immunohistochemistry and the alpha-synuclein particulate matter was studied. The demographics here, all of this, they have given the ID as L1 to L14 based on the genotype. L1 to L5 is G2019 and L6 to L9 is I2020, L10, and L11 to L14 is R1441. And except for the duration, which was duration of the disease, which was higher in 2019, almost the other demographics were matching in that of these in this 4 genotypic group. So another observation was in the Levy body related pathology, the duration of the disease was slightly higher when compared to that of the Levy body non-related pathology, which may be telling us that as the duration increases, the Levy body related pathology becomes more evident in those patients. And the second thing was in the 2019 group, there was 60% of the patients who had this Levy body related. However, the numbers were very less. The number of patients which they took was very less. And in this one, what we can see here is the 2 sections, that is the Levy body related and the Levy body non-related pathology, where patients without Levy body exhibited more abundant alpha-synuclein oligomers when compared to that of the patients who had Levy body related pathology. And the same thing here, as we can see, in the neurons and the neuropils. Neuropils are those structures which are apart from in the surrounding that of the cell body. So in 2 patients, that is in those patients who are not having a severity of the PD in the L1 and L2 group, they had more of this synuclein oligomers when compared to that of those patients with higher severity. In all the genotypic groups, more evident in the G2019 group. And it was also seen in the I2020 group in the L6 and L7 people who had a lesser severity of the disease when compared to the other patients with the higher severity. And also in those patients who are already having a Levy body, they have a lesser predisposition to the alpha-synuclein oligomers. Who are having who don't have the Levy body in there, they have more of the alpha-synuclein oligomers. So the observations were they are widespread and early. The oligomers are observed in as an early feature of the LRRK2-PD, and their presence is not dependent on the visible Levy bodies, and they may even decrease as the pathology increases, or the Levy body pathology or the duration of the disease increases. And this was seen in one of the other papers also, where in contrast to alpha-synuclein or aggregates, in contrast to the Levy bodies, may explain the cognitive impairment in the DLBD also. More the alpha-synuclein, more the pathology, or more the clinical presentation of the patient. So to conclude, alpha-synuclein does play an important role in the pathophysiology, even in the absence of Levy body. And as we can see in this image, it is just a formation of the Levy body from the alpha-synuclein in between particles like oligomers, protofibril oligomer, and then it aggregates and then forms a Levy body. So whether Levy body itself is a protective sink of these protein aggregates is a question. And whether the oligomers are more toxic than the Levy body, whether the duration of the disease will define the formation of Levy body has to be analyzed. And importance of this study was both it has got a pathological implication and a clinical implication also. Whether the targets of this therapy what we are giving should be targeted towards the oligomers which we are seeing. And the third thing was it defines also the duration prognosis. If there is more Levy body, that tells that the disease is already in the last or the later stages of the condition. So there is it has led to many questions and which can be answered. The future remains on targets And there was one of the trial in 2022, which was in early stages. This is a prasinezumab, which targeted the alpha-synuclein oligomers. However, it is still in phase 2 trial. Thank you.
Rohith has presented the article well. LARC2 mutations are one of the most common causes of genetic PD after GBA variants. So LARC2 mutations resembles sporadic PD. They have a tremor-dominant phenotype, tremor-dominant PD, which begins in the 60s, just like sporadic PD. And GWAS studies have shown that LARC2 polymorphisms are a risk factor for sporadic Parkinson's disease. The neuropathological criteria for Parkinson's disease mentions that there should be atrophy of the substantia nigra pars compacta as well as Lewy body detected on pathology. However, we know that some of the genetic forms, like Parkin mutations and some of LARC2 mutations, do not have Lewy body pathology. A study published in JAMA Neurology in 2015 showed that in LARC2 mutations, the patients who did not have Lewy body pathology still had motor symptoms, whereas those who had the Lewy body pathology, they had more of non-motor symptoms like cognitive decline, anxiety, orthostatic hypotension, etc. So we know that the presence of Lewy body is not necessary for a clinical diagnosis of Parkinson's disease. So this particular viewpoint looked into 2 studies using which detected alpha-synuclein and the Lewy body using techniques like proximal ligation assay and antibodies against alpha-synuclein. And they reiterated the fact that Lewy body need not be necessary, and it could be the alpha-synuclein oligomers which accumulate in different parts of the brain, which are enough to cause the pathology. So whether alpha-synuclein oligomers are more toxic than the Lewy body itself is the question they have asked at the end of the article. And probably more studies with larger number may be required to delineate the exact pathogenesis of this particular type of Lewy body negative LARC2 mutations. And it may have therapeutic implications also, because you can have targeted therapy targeting mainly on the alpha-synuclein oligomers, just like the study which is ongoing, as Rohith mentioned. So the studies, the viewpoint has given us more questions than answers. We need further studies which will look into the exact pathogenesis of these kind of genetic Parkinson's disease.
Thank you. That is for today. Thank you.